Thank you very much. It's a real honor to be invited here because I know the standard of talks and these type of lecturer that you've listened to are really top of their game. So thank you very much for inviting me. I'm going to be talking with trepidation on this title, Endurance Exercise, mostly good, but a few concerns. My disclosures are as follows. I receive an honorarium from the London Marathon, and I have received fees for assessing endurance athletes with cardiac problems. The objectives of my talk will be as follows. I'll discuss the overwhelming benefits of regular exercise on the cardiovascular system. I'll then briefly describe the physiological adaptation to regular vigorous exercise. And then I will broach the concept of cardiac maladaptation, but place it into context so that it's not overwhelmed with some of the media hype and the fear that some of you are subjected to. But the benefits of exercise on the cardiovascular system are well established. We know that people that exercise regularly are more likely to be of normal weight and therefore have better insulin sensitivity and less prevalence of diabetes mellitus. Exercise also improves your lipid and blood pressure profile, and by curbing all of these risk factors for atherosclerosis, exercise reduces your risk of a heart attack by 50% when you reach your 5th, 6th, and 7th decade. Exercise also reduces the prevalence of certain malignancies and gives you an extra 3 to 5 years of life. That's better than any pill that we've ever invented. But if we actually look at the impact of exercise on atherosclerotic risk factors, you'll see it's quite modest. Exercise brings down your systolic blood pressure by 5 millimeters of mercury, your diastolic blood pressure by 3 millimeters of mercury, your total cholesterol by 5%, your LDL cholesterol by 2%, and your body mass index by about 1.5%. So apart from curbing risk factors for atherosclerosis, exercise is associated with various structural, functional, electrical, and molecular changes that increase your peak oxygen consumption, which is an objective marker of longevity. So what exercise does is increases your cardiac size, improves cardiac filling, allows augmentation of stroke volume and therefore better perfusion of your tissues. It reduces aortic stiffness, decreases systemic vascular resistance, improves left ventricular compliance, stabilizes atherosclerotic plaques. In the periphery, it's associated with increased capillary conductance, better endothelial function, reduced oxidative stress, and reduced thrombogenicity. Electrically, you get a bradycardia, you get better ion channel expression, better electrical stability, and of course it also overall reduces myocardial inflammation, systemic inflammation. So these are the WHO recommendations of what we should be doing. And what they say in general is everyone should be doing 30 minutes of moderate exercise 5 times a week, or 25 minutes of vigorous exercise 3 to 4 times per week. And the recommendations suggest that we should be doing not just that, that's the minimum, we should be doing twice as much. But if you look at one of the largest meta-analyses that has been published, this included 174 studies with 150 million person follow-up, you'll see that that's the WHO reference. And this is really what you need to do to truly reduce your risk of diabetes, stroke, breast cancer, and coronary artery disease. And I think we should be doing 4 times the minimum recommendation. So instead of just doing 30 minutes a day, you should be doing 2 hours of physical activity 5 times per week. That is the norm. Now, clearly, our endurance athletes that you've heard about today do 15 to 20 times this amount of exercise. These people are a source of inspiration and aspiration to many of you, and they're one of the reasons why there are 800,000 running events in this country each year. Clearly, these individuals epitomize the healthiest segment of our society, and what happens with their hearts, they developed a plethora of structural and functional changes which increase in cardiac size, improved cardiac filling, better augmentation of stroke volume, and an increased peak oxygen consumption, which is manifest on the ECG, which reveals a bradycardia and a voltage criterion for left ventricular hypertrophy. But this is what an endurance athlete's heart looks like. So they get slow heart rates due to increased vagal tone. They get large QRS complexes because the heart size is big and their chest walls are relatively thin, so the heart is very close to the chest wall. They get a 10% increase in their left and right ventricular dimensions. They get a 10 to 20% increase in their left ventricular wall thickness. They get enhanced cardiac filling, even at rapid heart rates, and they can augment stroke volume, even at rapid heart rates, and the net effect is a high peak oxygen consumption. Now, the magnitude to which these adaptations take place is governed by several demographic factors, including age, sex, ethnicity, size, but also the type of sport and the intensity of sport. And some athletes develop very large cardiac dimensions. Here is a bar chart of left ventricular cavity dimensions in 1,000 Italian Olympiads. The red bars represent the females, and the blue bars represent the males. Females, being small with a lower lean body mass, generally have smaller dimensions compared to males. But the thing I want to emphasize to you is that the upper limit of left ventricular cavity dimensions in males is about 54 millimeters. 48% of male endurance athletes have a left ventricular cavity size that exceeds the upper limit for the general population. And 14% of these athletes have a left ventricular cavity size that exceeds 60 millimeters and would sometimes overlap with conditions such as dilated cardiomyopathy. So there can be a source of conundrum for us sports cardiologists when you're dealing with an athlete that's had a simple vasovagal syncopal episode at a marathon. They come to see a cardiologist and the heart's about that big and it looks a little bit lazy at baseline. You think, have they got a cardiomyopathy? When it comes to females, around 8% of females have an LV cavity more than 54 and about 1% more than 60 millimeters. So if we see very big cardiac dimensions in females, we do get concerned, but generally big cardiac dimensions are confined to endurance male athletes who are usually got a large body surface area. Clearly, there are some controversies surrounding lifelong endurance exercise. We know that there is, following marathon running, there is an increased concentration of biomarkers of myocardial damage. We know there is transient impairment of cardiac function after an endurance sporting event. Animal studies have shown evidence of cardiac damage following weeks and weeks of forced endurance exercise. There appears to be a U-shaped relationship between exercise dose and general health. And there are several human studies that have revealed potentially deleterious effects of lifelong endurance exercise on the heart, muscle, coronary arteries, and electrical tissue. Now, I want to put this all into context so you know what the real situation is, okay? In some cases, we don't actually know the answers. Let's start with an increased concentration of biomarkers of myocardial damage. I'm talking specifically about cardiac troponin, which is found in the sarcomeric contractile apparatus. We find that the identification of troponin after high-intensity endurance exercise, such as long-distance cycling, is common. It's present in about 50 to 80% of people. So 50 to 80% of people that finish the marathon tomorrow will have an elevated serum cardiac troponin if you checked it. This occurs in ostensibly healthy and completely healthy individuals. Post-exercise cardiac troponin values may be 10-fold higher compared with pre-exercise values. And most athletes that have finished a marathon or equivalent will have a troponin concentration that is 1 to 3 times the upper limit of normal. Now, what does that actually mean? Well, if we look at the kinetics of troponin release after myocardial infarction, at the top there you will see the sarcomeric contractile protein where 90% of all the troponin lives. If you've got genuine myocyte necrosis, there is breakdown of the sarcolemmal apparatus which results in a gradual increase in troponin which remains elevated for between 3, 5, and even 6 days. In contrast, there is 10% troponin in your cytosol. We believe that exercise is associated with increased membrane permeability due to heat, beta receptor stimulation, acidosis, mechanical stretch, and this troponin appears in the bloodstream within 2 or 3 hours of completing exercise. It remains elevated for about 24 to 36 hours, and it's completely gone after that. There is no study to date that has actually shown a correlation between raised troponin levels post-marathon and myocardial inflammation or myocardial scar, but there are emerging studies that have shown that there is transient myocyte increase in myocyte permeability that allow this phenomenon to occur. There is also transient impairment of cardiac function. It's true to say that if one of you finished a 3-hour marathon and I did an echocardiogram on you, I would find that your heart is a little bit bigger than it was before you started, and it's a little bit more lazy than it was before you started. But if I did the scan again in 2 or 3 days' time, everything's gone back to normal. Just like your muscles hurt after 3 hours of exercise, your heart doesn't hurt, but it shows that it has been flogged a little bit, but it regenerates and it gets better very, very quickly. What about animal studies? Again, because these hit the headlines quite a bit, and I'll talk about the animal studies next. So these are animal studies. Remember, they're forced animal studies. You can't make a mouse or a rat run just because they feel like running. You've got to force them to run. So you put a mouse like this on a treadmill, and every time it stops, it gets an electrical shock. And you do this for 60 minutes a day for 16 minutes. That's like running a very fast 10K for most of your life. And then these mice are sacrificed. And when they're sacrificed, what you see is that their chambers are enlarged, particularly their atria, and there's scarring in the atria, and there is scarring in the right ventricle. You also find that the heart muscle doesn't relax as well, and if you do electrophysiological studies on these mice and rats, you find you can induce ventricular tachycardia very easily. Now that sounds very scary, but remember, we are human beings, we're not rodents. We are not being electrocuted every time we stop running, so there's a stress response involved there as well. The second thing I should tell you about that the media don't enlighten you to is that they kept some of these mice. So after they'd stopped exercising, they didn't sacrifice them. They kept them. They sacrificed them 10 or 15 weeks later. And they found that all these changes they found in the exercising mice had completely resolved, suggesting that in some cases this may be a compensation mechanism, just like you see in your Achilles tendon. There is a U-shaped relationship between exercise dose and general health, just like there is with everything else. The previous speaker just said, you can get too much of a good thing. And of course, when you start doing something, there is a point of diminishing returns. The more you do it, the less benefit. And in some vulnerable individuals, that benefit may turn into deleterious effects. The best studies I've come across, and no study has ever proved to me a genuine U-shaped relationship. And I'm not being biased. I look after endurance athletes with cardiac problems. They've shown that there's a law of diminishing returns, but never that things go bad. I've not seen a convincing study. So here you've got the ability to exercise in METs and your risk of cardiovascular deaths. And the fitter you are, the better your outcome, the less likely it's for you to have a cardiovascular death. In fact, for every MET an individual can exercise, they reduce their risk of an adverse cardiac event by 13 to 20%, up to a point of about 13 METs. That's running about 12 to 14 kilometers per hour. Anything that you run faster than that, you're running for aspiration and goals, not for cardiovascular health. What about human studies? Well, let's talk about atrial fibrillation. In fact, during the COVID pandemic, when I wasn't allowed to see patients face-to-face very easily, the most phone calls I got was from our veteran athletes who had gone into AF during the COVID pandemic. Well, it's true to say, atrial fibrillation, as you know, is one of the commonest arrhythmias. It's present in about 10% of our octogenarians, and we don't expect to see atrial fibrillation in healthy people in their 40s or 50s. But if you actually compare our athletes, our male athletes who are in their 40s to 60s, with our general population of the same age, we find that the risk of atrial fibrillation in our male veteran athletes is fivefold greater than in the general population. Now, clearly, what happens to the general population with atrial fibrillation doesn't generally happen with athletes. For example, if you've got atrial fibrillation, you increase your risk of all-cause mortality by 2%, your risk of stroke by 5%, and your risk of heart failure by fivefold and threefold. That doesn't seem to be the case in athletes. But the sort of athlete that gets atrial fibrillation is someone who's male, aged between 40 and 60, who's engaged in endurance sport for around 21 years, and who is usually tall. And our theory is that these tall individuals have very high blood pressure responses, and part of the reason to this AF is the fact that they get high blood pressure responses, which puts a lot of load on their left ventricle and on their atria. The theory is that clearly if you exercise a lot, just like you stretch all your other chambers, you stretch your atria. There is evidence that you get myocyte hypertrophy and inflammation from certainly animal studies, and some biopsy studies in humans have shown that there is atrial inflammation and atrial scar that may promote atrial fibrillation in some individuals. Increased vagal tone causes bradycardia, and it shortens and reduces the dispersion of the atrial refractory period, which may promote atrial fibrillation, as may gastroesophageal reflux. A lot of athletes often say, I started belching, and shortly after I belched, you imagine the esophagus is right next to the left atrium, so you've got lots and lots of reflux, and you've got increased vagal tone. Some of these individuals may develop atrial fibrillation. Of course, there is the issue of genetic susceptibility, because not everyone develops AF. And there is the issue of performance-enhancing drugs. Some people may take agents that make them go faster, which may put them into atrial fibrillation. What about right ventricular dysfunction? Some of you may have heard of the concept of exercise-induced arrhythmogenic right ventricular cardiomyopathy. We talk a lot about the left ventricle because the left heart seems to supply the body, but we forget to talk about the right ventricle. This is basic physiology in the left ventricle and the right ventricle. Your both ventricles are subjected to the same cardiac output, 5 liters per minute. If you look at the resting vascular resistance, it's much, much higher, 1100 on the left side versus only 70 on the right side. If you look at loading conditions, the blood pressure is higher on the left side, 130 systolic versus 25 diastolic. Now, when someone starts to exercise, the cardiac output goes up by 5-fold to 6-fold, so 25 to 30 liters per body, to 30 liters per minute, and both ventricles get that. Now, on the left side, your systemic vascular resistance drops due to acidosis, buildup of ADP. You get vasodilatation, and you get quite a significant drop in the systemic vascular resistance. In contrast, there is a very small drop in the pulmonary vascular resistance, and therefore the loading conditions go up significantly on the right ventricle. So people who are exercising vigorously can get pulmonary artery pressures of up to 80 to 90 millimeters of mercury. There was a Belgian group, and they've been very, very prolific since then, that reported a very select group of athletes. These weren't all athletes. These were athletes presenting to them with syncope, ventricular tachycardia, or sudden cardiac arrests. These were about 48 athletes. They reported them. And what they found in these 48 athletes was many of them had a big right ventricle that didn't seem to be working very well. And they were showing rhythm disturbances coming purely from that right ventricle. They did genetic studies to look for a condition called arrhythmogenic right ventricular cardiomyopathy, which is a condition characterized by fibrofatty replacement of the right ventricular myocardium that predisposes to arrhythmias. And they found that whereas in the general population of people with this condition, 40% have a pathogenic mutation, the athletes, only 12% had a pathogenic mutation, suggesting that exercise was contributing to this disease process in predisposed individuals. They then did a study where they took ostensibly healthy athletes, about 40 of them. These athletes either participated in the Ironman or the marathon, and they had troponin measurements pre and post exercise and echocardiograms pre and post exercise. And what they found was post exercise, the left ventricle looked shrunk and small and empty. The right ventricle looked big, dilated, and wasn't working properly. And that correlated with the magnitude of troponin. In fact, that's one of the only studies that's correlated troponin levels with cardiac function. And they hypothesized that ongoing insults like this on the right ventricle in some people may eventually result in progressive scarring of the right ventricle, causing it to become weakened and causing it to become arrhythmogenic. We know that people who've actually got ARVC, so if you've got ARVC and you run marathons, there is plenty of data from animals and humans that you will accelerate your phenotype. So the true feeling is, when I can move it, sabotage, I think. I got it there. Okay. I don't think it likes that next slide. But what that next slide was showing was there has to be an interplay between the environment and genetics. That not everybody who runs gets AF or ARVC or scar in the tissue. There are some people that have got a genetic predisposition, and if you superimpose upon that the insult of an afterload, whether that be exercise or something else, you may unmask that particular problem. Now, I'd like to talk about coronary artery calcification. This study caused massive headlines because until this study came out, we believed that marathon running protected us from all sorts of heart attacks and everything else. So this German study took 108 male marathon runners aged between 50 and 72 years old and compared them with 864 matched, apparently healthy controls. The coronary artery calcium score, which is a marker of atherosclerosis, was higher in marathon runners when you corrected it for their Framingham score. Equal numbers of marathon runners and controls had a coronary artery calcium score of over 100, which I'd consider as high. They then did MRI scans in these athletes, and they found that 12 athletes had scar, of which 5 had scar suggestive of a previous heart attack, and 3 of these individuals went on to have serious events afterwards. And when this study came out, it was all sorts of headlines like running for your life, running against your life, suggesting that marathon running may be detrimental and counterintuitive to good coronary health. But one thing that they didn't tell you was that 50% of these runners were smokers and had multiple risk factors. So you might be able to run, but you can't run away from your genes, and you can't run away from concomitant risk factors that you haven't dealt with. So I was sat there and thought, look, we've got to do something. We've got to do a really clean study where we take a load of people who have never smoked, who've got a pristine blood pressure, pristine lipid profile, no family history. Now, you can imagine how hard we had to work to find those types of middle-aged individuals. And they had to be middle-aged, and they had to be running for at least 10 to 15 years, lots of races. So we took a load of people who had exercised for 31 years. 77% of these were marathon runners. They'd run a median of 13 marathons. We had 16 national champions and 5 world champions. Now, I'm very pro-female research, but I'm only going to show you the male side in a minute. I'll deal with the females afterwards. But that's because the females were protected, but I'll talk about them later. So here's the difference between male controls and male athletes. You'll see they're roughly the same. You've got 106 athletes and 54 controls, roughly the same age, roughly the same Framingham score risk. So they've got a low atherosclerotic risk profile. Around 50 to 60% of these people had a completely normal coronary artery calcium score. There was no real difference in the coronary artery calcium score above 100, above the 50th percentile, or above the 70th percentile. But what we did see, we were seeing a signal at a coronary artery calcium score of 100. You'll see that nearly 20% of our marathon runners had a coronary artery calcium score of above 100. Now, that did not hit statistical significance, but it did make us look in more detail. So we started looking at the people that had the highest coronary artery calcium scores. Another case of sabotage coming up here. But what we found, in case this slide doesn't work, is that we found 11% of our cohort had coronary artery calcium scores over 300. They were all athletes. We didn't have any healthy control that had a coronary artery calcium score of over 300. When we looked at the coronary plaques, our runners had twice the number of coronary plaques as our non-runners. We've now skipped too far now. Yeah, twice the number of coronary plaques as our non-runners. So we started thinking, gosh, this doesn't look very good. Then we started looking at the morphology of the plaques. Now, some of you may remember, or I'll tell you, that plaque can either be thin with a fibrofatty cap. These are the plaques that rupture and cause heart attacks. They can be hard, rock hard, loaded with calcium. These are the plaques that are stable. So what we found was if we compared our male athlete with our male controls, where the blue bars represent calcified plaques, the vast majority of our athletes had calcified plaques compared with our non-athletes who had mainly mixed morphology plaques or high fatty plaques, suggesting that whatever's going on in the coronary arteries that's causing the calcium is a repair mechanism of some form or the other, but it's different to the repair mechanism that occurs with hypercholesterolemia, hypertension, or cigarette smoking. Now, if you imagine that your coronary arteries are like an elastic band, if you kept stretching it 90,000 times a day, that's your normal lifespan without running, and you were bending it and flexing it, it would get some wear and tear in it. At the same time, when we published in Circulation, another Dutch group published this. They compared the relationship between exercise dose, coronary artery calcification, and coronary artery plaques. They divided people into people who did very little exercise, less than 1,000 minutes, people who did a moderate amount of exercise, between 1,000 to 2,000 minutes, and people who did a lot of exercise. Now, even that definition of more than 2,000 minutes, that's 4 times the current WHO recommendations. Nothing like what our athletes do. What they found is that the more that people exercised, the less likelihood that they were going to have a coronary artery calcium score of 0, and they had higher coronary artery calcium scores, and they also had a greater number of plaques. So what's causing all this? So this is our theory. We feel that repetitive mechanical stress due to the bending and flexing of the coronary arteries may be responsible. A hypertensive blood pressure response, we've just done a study, it's not published, I'm not going to talk much about it, but we've shown that for every 5 millimeter increase in your ambulatory blood pressure or exercise blood pressure, you increase your risk of calcified plaques, soft plaques, and high-risk plaques by about 20% if you do that. So one thing we can do for our athletes is treat hypertensive blood pressure responses in our middle-aged and older athletes, because that may reduce the risk of atherosclerosis. There are other mechanisms that when you're stamping the ground hard, you're releasing parathyroid hormone, which may be causing ectopic calcification, and inflammation may be also contributing. But of course, there are other things. There are certain things such as age and male sex, the amount of exercise and genetic predisposition that may be contributing, and the fact that some people think just because they ran a marathon, they can scoff cakes left, right, and center afterwards, which they clearly can't. So what does it all mean? You know, a runner comes up to see me and says, look, doc, you know, I went to have a well-man check. I've run 15 marathons, and my coronary artery calcium score is 200. What does this actually mean? Am I going to drop dead? Well, there is some data here on 8,425 men without established cardiovascular disease who had a cardiorespiratory fitness test and had a coronary artery calcium score. They were followed up for 8 years, and we looked for hard points such as deaths, heart attacks, and strokes in individuals with 4 categories of coronary artery calcium score. A coronary artery calcium score of 0, a calcium score of 1 to 99, a calcium score of less than 400, and a calcium score of more than 400. Clearly, the hard events increased the more calcium you had. So, you know, obviously, so this is, the more calcium you have, the higher your risk of a hard event such as stroke. But here, this graph shows you the incidence of cardiac events on the x-axis, your fitness levels on the y-axis. Then you've got these various curves where the black curve represents a coronary artery calcium score of 0, and the red curves represent a coronary artery calcium score of more than 400. So even though coronary artery calcium scores did predict risk, if you were fit, the fitter you were, the lower your risk. So if you had a coronary artery calcium score of more than 400 for 25 years, that's a long time, and you were really fit, you reduced your event rate from 5-fold to 2-fold. In fact, for every MET an individual could exercise with this calcium, they reduced their risk of event rates by 14%. So I only treat coronary artery calciums in runners who have actually got risk factors for atherosclerosis, not otherwise. There was another study that looked at what happens to these people with very high coronary artery calcium scores that carry on exercising versus people who've got similar coronary artery calcium scores that don't exercise as much. So this is data on 22,000 people who were in their middle ages who self-reported their exercise. So the exercise dose was divided into high, moderate, and low. And at least 24% of this cohort had a coronary artery calcium score of 24%. The more people exercised, the higher their coronary artery calcium. And these guys were followed up for 10.4 years, during which there were 50 cardiovascular deaths. Men exercising at a high workload with a coronary artery calcium score of more than 100 did not have an increased risk of cardiac mortality compared to those exercising less with the same calcium. So this data suggests that if you carry on pushing yourself with this calcium score, there is nothing to suggest that you're suddenly going to drop dead. What about scar tissue? Now, this may affect some of you. Some of you may have had an MRI scan as a research tool, and someone will say, you know, you've got a bit of scar in your heart. And you think, scar? Scar means arrhythmia. So let's talk about scar. If I tested middle-aged marathon runners, I would find scar in the right ventricular insertion point. That's the point where the right and the left ventricle come together. I'd find scar in 40% in the right and left ventricular insertion points. It's so high that we don't even take notice of that. We think that's just a hinge mechanism, pulling, pushing, that causes scarring. But we find scar, depending on the studies that you read, between 5 and 20% of endurance athletes. The scar is usually subepicardial or mid-wall, which probably represents myocarditis, but I suspect it represents years and years of running. It has to be. You can't say that all these runners got myocarditis. So I think it does partly represent years and years of running. And what happens if you've been running all your life? Of course, there's a genetic predisposition. You've got an accruing age-related atherosclerotic risk factors. There's demand ischemia on the heart and possible microinfarction. You're exposed to toxins and infections. There's the stresses of exercise and also performance-enhancing agents that may give you scar. We don't see scar in women, okay? Just like we don't see coronary artery calcium in women, we didn't see scar. Here's probably one of the best studies relating to scars, original studies that is, others are all meta-analyses. 83 triathletes, middle age versus 36 controls. They found that 17% of these triathletes had scar. The scar was around the infralateral wall, and most of the scar looked like it was related to something like myocarditis. But what this group showed was they could correlate scar in people with hypertensive blood pressure responses. That was one important thing that they showed, and that's what we've been saying all along, that a high blood pressure response to exercise may contribute to calcium and scarring in the heart. They also correlated with high cycling mileage and a greater number of middle distance and Ironman events. In fact, a completed cycling race distance of more than almost 1,900 kilometers during a competitive race had a high sensitivity and sensitivity for myocardial scar. So athletes do get scar. There are various reasons for this scar, which may be running related, hinge point stretching, but also maybe microinfarctions in some of these people. But there is genetic susceptibility, hypertension, chronic pressure, and volume overload. I'd like to finish with sex differences. Just like our previous speakers have said, we've not done enough research in female athletes, and they are an increasing group of athletes that are participating in marathons and so forth. Here is our original study comparing men and women. This is the coronary artery calcium score going from 0 to 400. Men in the blue bars, females in the white bars. You'll see that females have a far higher prevalence of increased coronary artery calcium than men. And when this paper came out, we tried to make a big deal of it, but the editor said, hold on a minute, you can't make a big deal of it, because you compared the women of the same age to men. And women age 10 years later than men do when it comes to their cardiovascular system. They questioned us about the protection from estrogen, and they said, go away and do another study on postmenopausal women. That's what we want you to do. Go away and tell us in postmenopausal women. So we did hold on. So in this study, we found that whereas our male athletes had predominantly calcified plaques compared to our male controls, in females, whether you're an athlete or a control, any plaque that you had was calcified. So they seem to be protected all along. We then went and did this postmenopausal study. This has not been published yet, but it has been presented at several meetings, where we had 221 females versus 61 healthy controls, of which 70% were postmenopausal. They exercised quite a lot, as you can see, 32 years of exercise these women did. They were exercising 8 hours per week. They had very high peak oxygen consumption. What we found in women, interestingly, was that female athletes actually had less calcium than female controls. We found the same with AF, that if men exercise a lot, they increase their risk of AF. If women exercise a lot, there's an inverse relationship of the risk of AF. We found the same with calcium. Females exercising a lot had less calcium than females who weren't doing, and we don't see scar in women either. Now, we may never find that out, because a woman usually reaches menopause at the age of 50, because I think that's what it's all about, estrogen protection. Now, I don't think we'll be able to exercise 90-year-old women, and if we do, I mean, unless we start living much, much longer. So I don't think we'll ever have the answer. All to say that women are protected, and that almost certainly explains why we hardly see any female deaths at mass endurance events. So I've given you an idea of adaptation in the blue and maladaptation in the red. And I'd like to finish up with my last slide as to how I see endurance sport and health. So Here are all the goods and the bads. So cardiovascular events on the X and the amount of exercise you do on the Y. So people who do what the WHO says, reduce their risk of obesity, hypertension, diabetes, risk of AF, and increase their functional capacity and improve their prognosis with heart failure. These people may even do 5 times as much and be protected. A small number of people get a high troponin rise, which we believe is physiological, but some people do get AF. They do get increased coronary artery calcium, they get scarring, and they get RV dysfunction. This may be partly influenced by their genetics and the environment, and this may be bad. And the one thing that we dread, and this has nothing to do with exercise is just a trigger, but there are some people who've got vulnerable substrates such as coronary artery disease, cardiomyopathies who don't know they've got it, and sometimes these people do succumb to mass endurance events, and then this does become very ugly. I hope we won't see anything ugly tomorrow. I want to leave you with this though. Athletes definitely live longer than the general population. There is no doubt about that, and that has been proved again and again and again. So thank you very much.
Thank you so much for another fantastic talk. So I'd like to invite all the other speakers to come back up onto the stage. And just while we're doing that, if there's any questions for Sanjay, please put your hand up. Anyone at all? Yes, Joe in the middle there. There's a microphone coming your way now.
Hi, Professor Sharma. Thanks very much for that talk. Given with professional athletes that are doing high volumes of endurance training, is there any steps that governing bodies or healthcare providers looking after those athletes can take to diminish the risk of some of the pathologies you discussed?
Well, I mean, I can't answer that because I do work with professional athletes, but they only get referred to me if they've got a cardiac problem or suspected cardiac problem. So I don't see ostensibly healthy people. I mean, I would only see someone like Mo Farah if he had a blackout or something like that. Otherwise, someone like him wouldn't come to me. So I don't quite know what's done about managing or mitigating their atherosclerotic risk profile. And I don't know if there are any studies that have actually looked at coronary artery calciums in the sort of people that Andy was talking to us about. These are these are machines, we can ask. I don't know what their arteries look like. People could argue that they're different to us because they're superhumans, they're not real normal humans, and it may be that what you see in them is so different to what you'd see in any of us. But I'd love to know myself. Would
regular screening of some kind, like with the CRY sort of project?
Well, no, I think you're right. I'm pro-screening, as you know, but screens are very good because so many people exercise, we've got to be very, very careful how we screen. It's got to be pretty cost-effective. So if you're going to do something cost-effective, it's going to be based on something like a health questionnaire and a 12-lead ECG because they're cheap. And it's true to say that an ECG will pick up things like long QT, Brugada, Wolff, Parkinson White, may even raise suspicion of a cardiomyopathy. But the ECG is pretty useless for coronary artery disease. And of course, if we're going to look for coronary artery disease, we need to be doing functional imaging, CT coronary angiograms, which wouldn't be practical. So we'd probably reserve those for research tools or someone who've actually got multiple risk factors. So we normally say in our guidelines, if you've got multiple risk factors for atherosclerosis or worrying symptoms, then someone like that should be investigated.
Thank you. There's a question here in the middle.
Thank you for your talk. Given that we now live in a post-COVID era, and you mentioned that the pattern of scarring that you're seeing in endurance athletes looks like myocarditis, if you started to see more patterns of scarring now, would that kind of make you think about a different etiology? So, for example, athletes are more likely to exercise through minor illness, which may result in myocarditis.
Well, we do have some data, thanks to financially endowed sporting organisations such as the FA. As you know, the Premier League had to return. They had to return early because clearly there were broadcasting financial issues. People weren't going to pay up if the season didn't finish. And also they were concerned about the mental health of football fans who really wanted to do something, watch football. So these players came back and they were tested left, right and centre. They had SARS-CoV-2 tests done on a regular basis. And those that came back positive in the early days did get tested. You know, they had the whole shenanigans. They had troponins, ECG, echo. And what we found was that the prevalence of myocarditis in this group was between 0.7 and 3%. So if you had COVID, the risk of you getting myocarditis was between 0.7 and 3%. Now, the good news is that the vast majority of those people actually had cardiac symptoms. So you could pick those up. But about 20% didn't. And this begs the question whether you get a viral illness. And of course, the pressure to perform is so high that most people would say, you know, it's only a mild viral illness, I'm going to keep going. And whether that causes, you know, subclinical inflammation and scarring in the future is unknown. And I think what we should be doing is maybe doing a study on athletes who've had any viral illness and seeing what the MRI looks like 2 weeks later.
Great. One more question for Sanjay, yeah?
Yeah, so I'm kind of wondering, it sounds like a lot of the problems caused by exercise are related to a high blood pressure response. And I'm wondering if that kind of gives room, is it worth us looking at and potentially treating high-intensity athletes or endurance athletes that are normotensive, that have a high blood pressure response?
Yeah, it sounds like a bizarre thing, doesn't it? That you've got someone who's got a completely normal blood pressure, exercise is good for your blood pressure, you put them on a treadmill and they get a systolic blood pressure of 260. You know, and you think, should we be treating it? As I said, this is emerging data, and the emerging data looks really good. That, you know, it's these guys that have more calcium and more scar. And I think if there are other studies that can reproduce that, I think there would be mileage in treating people who've got hypertensive blood pressure responses.